Good morning, everyone, and welcome to today's clinical meeting. We'll start with our first presentation from Medicine 5, Dr. Dorene Juana, Encased.
Good morning, everyone. I'll be presenting on behalf of Medicine 5. The topic for today is the Encased. The case I'm going to be presenting is Mr. P, a 21-year-old gentleman who presented with complaints of chest pain for 3 months and breathlessness for 3 weeks. His chest pain was retrosternal chest pain, which was worsening with deep breaths and coughing. He had no radiation. The breathlessness began 3 weeks ago. It was progressive dyspnea with progress from NYHA class 2 to class 4. In the local hospital, he was evaluated and he was found to have a pericardial effusion for which they had done a pericardiocentesis and 500 ml was drained. 10 days later, he had similar dyspnea at rest and he was again noted to have a pericardial effusion, and this time 1500 ml was drained. He had 2 episodes of syncope, which was lasting less than 2 minutes during this duration of 3 weeks. But there was no history of any confusion or tonic-clonic movements or memory impairment, which was associated with the episode. There was no history of fever, cough, or hemoptysis, no history of weight loss, loss of appetite, no history of joint pain, oral ulcers, or photosensitivity. On examination, he was noted to have a pulse rate of 120. When he presented to CMC, pulse rate of 124, respiratory rate was 24 per minute, temperature was 98, blood pressure was 110/70. He was maintaining saturation. General examination, he was noted to have dilated neck veins and JVP was elevated. Systemic examination, TVS examination, first and second heart sound was heard in corresponding area and muffled heart sounds were present. The other systemic examination was normal. The clinical syndrome that he presented with progressive breathing difficulty with history of recurrent pericardial effusions with impending tamponade. The history was more in favor of a cardiac onset of breathing difficulty. And in view of this history of twice recurring pericardiocentesis, the likely etiologies that were considered for his recurrent pericardial effusion were either infective origin, malignant, or autoimmune. Infective, so the most likely diagnosis of TB, viral such as Coxsackie virus, EBV, fungal and parasitic, though were extremely very rare. Malignant again had cardiac causes and non-cardiac causes were considered. In cardiac causes, malignancy, primary malignancy like rhabdomyosarcoma or angiosarcoma, and non-cardiac lymphoma, germ cell tumors, thymoma, if there's any metastasis to the mediastinum was looked at. His investigations, his baseline profile is hemoglobin was 12.2. His total counts was 7,300 and neutrophils of 68. His renal function and his hepatic, there was no hepatic functions were normal. INR was 1.1. Pericardial, when he presented here, the pericardial fluid analysis, which was done with the first tab, his WBC was 2,200 with lymphocytes of 95%, and RBCs was 40,000. LDH was 530. Cytology was this thing for bloodstained smears with lymphocytosis, and expert PCR, MTB was not detected, and culture had reported no growth. We had done an echo, which had shown there was a large pericardial effusion, which was present in all surrounding the heart, and swinging motion of the heart was present. There was an echogenic irregular mass was noted in the right atrium, which has appeared to be extending from the SVC. His other cardiac function was normal. It was normal LV function with an EF of 58%. This was a bedside echo which was done, on which we can see that the mass arising in the right atrium. Coming back to our probable etiologies that we had considered for his recurrent effusions, at this point post the echo, we had narrowed it down to a malignant, either neoplasm, this thing, probable cardiac or non-cardiac causes for the recurrent effusions were there considered. He was followed up with a cardiac CT, which had shown that there was a mass insinuating the right atrium, the cavo-atrial junction, which was encasing the ascending aorta and the proximal arch, and the left pulmonary artery, and the entire of the right pulmonary artery, and it was abutting the distal trachea and the mid-esophagus. It was also encasing, spreading into the left atrium and to the right pulmonary veins, ostia. And there was also an extensive pericardial effusion which was noted. Based on this, we had confirmed that it was a cardiac tumor, and hence I will be looking briefly on how to approach a cardiac tumor. Just a small brief note on that malignant tumors are extremely rare, and they are actually only up to like 5 to 6% of the primary cardiac tumors, meaning that the rest of it all are mostly just benign tumors. Out of the malignant, sarcomas are the most common, which comprises around 64%, which are followed by lymphomas and mesotheliomas. When we see there is an echo in a cardiac mass in an echo, the different thing that can be considered is first primarily a tumor, a thrombus, a vegetation, or it's a structural anomaly. In tumor, so the most common thing that it can be is likely to be a secondary tumor or a metastasis, in which we have to further follow with investigation of probable CT neck thorax abdomen to look for the probable primary. The most common primaries are from the lung, breast, esophagus, or pancreas, and hematological malignancies like lymphoma and leukemia. The primary tumors of the heart are by baseline very, very extremely rare, and of which 90% of them are most commonly primarily benign. Malignant primary tumors are comprising only around 10% of the tumors. Again, when we look at a benign malignancy, benign tumor, based on the age of the patient, again, there are in a pediatric population, it is more likely to consider rhabdomyoma or fibroma or teratoma, whereas in an adult, most commonly what we look at will be a myxoma. Further imaging modalities, when we know that a patient has a cardiac tumor, the advanced 3D echo or cardiac MRI, a cardiac CT, or a PET CTs are also done mainly to characterize the tumor and for prognostication and for staging and for planning the next step, whether a biopsy or plan for a chemoradiation therapies. Most of when we look at histopathology, the benign tumors like myxoma, lipoma, fibroma, or rhabdomyoma do not usually require a biopsy for confirmation. They are usually conservatively managed, or surgical resection is done. But when we look at malignant cardiac tumors like an angiosarcoma, a leiomyosarcoma, rhabdomyosarcoma, usually they will be requiring a biopsy, and surgery is the first modality of treatment in first modality of treatment, followed by chemo or radiation therapy. In our patient, he had undergone a CT-guided biopsy. The biopsy's preliminary report was suggestive of a high-grade spindle sarcoma, which was in favor of a high-grade angiosarcoma. Surgery is the first modality of treatment that is considered, but in his case, it was it was not possible because of the extensive involvement in the mediastinum. Radiation, RT was also involved, but radiation also was not feasible due to the extensive involvement. The patient was advised chemotherapy with paclitaxel, and in view of financial constraints, he had opted to continue his chemotherapy in his hometown. He was advised to undergo at least twice daily aspiration of pericardial fluid. This is a brief case report on a patient with the primary cardiac angiosarcoma. This gentleman also had a similar presentation and age profile as my patient. He was a 19-year-old man who had presented with a 3-month history of hemoptysis and 1-week history of anterior chest pain. Echo was done, which had shown there was a pericardial effusion, from which 1,300 ml of hemorrhagic fluid was drained. The echo also had confirmed that there was a right atrial mass which was present. And in view of his hemoptysis, thoracic CT was done, which had shown that there was bilateral pulmonary nodes with halo and alveolar densification suggestive of pulmonary metastasis. Cardiac MRI done, which it was followed up by a cardiac MRI, which had shown there was a large mass on the right atrium's anterior wall. Biopsy performed had shown that it was a cardiac angiosarcoma. And the lung lesions were also biopsy, which had shown such features of confirmed that it was a metastasis. The patient was submitted to palliative chemotherapy, but had died from 12 months after his diagnosis. The cardiac angiosarcomas are extremely rare, but they're also the most common primary cardiac sarcomas. And they are a very aggressive tumor, and the prognosis is very poor, with a mean survival of 6 to 12 months from the time of diagnosis, despite all expensive therapeutic options.
Thank you for that presentation. Any comments from the audience? We move to the next presentation from Medicine 3, Dr. Vivek, Paradox.